Good morning, everyone. How are we doing? Excellent. Welcome to CareOregon, and you are here for the March 1st MEDS Ed, our first real MEDS Ed of 2019. I believe we have a couple of newcomers who've never been to a MEDS Ed program before. If you wouldn't mind self-identifying yourself here. Excellent. Welcome. Quite a few folks. That's great. We tend to do these on a bi-monthly cadence about 4 or 5 times throughout the year. So you'll have other opportunities to come and get education from us here. This particular chapter of MEDS Ed today is sponsored by CareOregon's Pharmacy Department and our good friends and partners at the Oregon Clinic. So you're in for a treat. Lots of good practical information that you can take back to your environments and start using right away on the topic of COPD. A couple things for you. You have quite a few handouts today, including the new pathway, that larger document that'll help streamline treatment for COPD. You'll be referring to that throughout today's activities. If you haven't already filled out the top half of our session evaluation forms, I ask you to go ahead and do those and let us know where you feel you are on the current state of your knowledge on those top 3 learning objectives, and then you can revisit that at the very end of the session. We've also got some handouts for you, some nice patient education tools if you have folks that just need some friendly reminders about how to help make sure their treatment is going well. We have these longer handouts you can give folks. We have plenty of those for your distribution today, so take some of those with you if you have some patients you think would benefit from those. But we have a lot of good content, so we don't want to delay. We want to get right to it here today. We are fortunate to have kind of serving as ringmaster of our events today, a phenomenal presenter who I would think you would have to call pulmonologist extraordinaire. Probably the only introduction that I think would be appropriate. From the Oregon Clinic, Pulmonary Medicine and Critical Care Medicine, please give a huge welcome to Dr. Rhett Cummings.
Thank you. I think, can everyone hear me? So we have, I don't deserve most of that introduction. Yes, I am a pulmonologist and I've worked at the Oregon Clinic, and we've had a pretty unique relationship with CareOregon and the population that CareOregon serves for many years, even dating back to pre-CareOregon days. So I think I'll probably just jump into it. I know that we have various levels of education and training in the audience, and so feel free to stop me. Hopefully we'll have time to do that throughout the talk. If there's something you need clarified, we do have time for questions at the very end of each of the sessions. And I'll be followed by a few other people that will be covering in more detail some of the things I touch on in my parts of the talk. And then at the very end, we'll kind of wrap it up, hopefully. So I think I'll just jump in. And the other thing that I may be flipping back and forth between reading glasses and non-reading glasses, just so I can see some of my notes up here. So if it's a little bit weird or awkward, just bear with me. So, by and large, COPD is a preventable disease. So you can't really have a discussion about COPD without talking about smoking. About 80 to 90% of COPD is smoking related. The other etiologies or causes are pretty minimal and rare. It's air pollution, alpha-1 antitrypsin disease, and other exposures. But you know, what are the costs of smoking in our country? And the magnitude is a little bit overwhelming if you look at some of the data, especially if you look at some of the CDC data and CMMS data. So in 2016, tobacco companies spent about $1 million every hour on advertising. That's $9.5 billion in marketing every year. If you look at the top 5 companies, tobacco companies in our country, their combined sales were $150 billion. That doesn't include China, which is about half the world. And they had a profit of about $36 billion, which is about the gross domestic product of Kuwait. So that's just sales, okay? Smoking-related illnesses in the U.S. cost more than $326 billion a year. That's direct medical cost of $170 billion, and then indirect of about $150 billion or more. That's loss of productivity due to secondhand smoke exposure and primary smoking-related hospitalizations and missed days of work. This is about the gross domestic product of Pakistan. Okay, this is just smoking. In the U.S., our healthcare spending is growing exponentially as a proportion of our GDP. So in 1960, about 5%. In 2012, it's at about 17%, and it's projected to continue to rise. Okay, so it's $3.5 trillion a year. That's what we spend on healthcare here in the U.S. That's about almost $11,000 per person, per individual in the U.S. is spent on healthcare, and it's almost 18% of our gross domestic product. If you back out of that and look at smoking-related disease, it's 8.6, and then I lose it. Oh, there we go. It's 8.6% of our healthcare spending is on smoking-related disease. It's almost $1,000 a person per year, smoking-related alone. And smoking-related disease is 1.5% of our gross domestic product. So that's a huge amount of dollars that we spend just on smoking. What about lives? Okay. So 480,000 deaths a year in the U.S. smoking-related. By and large, they're lung cancer, ischemic heart disease, and COPD. 100,000 or more deaths a year, COPD deaths a year. If we were to ban smoking, this would be cut to, what, about 9,000 deaths, okay? A lot of money spent, a lot of deaths. When we look at the population of smokers, there is a definite correlation between poverty and education. So although you see that there's some good news when you look at these graphs, and these are from 1983 to 2011, those below the poverty line are always about 10% more likely to smoke than those that are above the poverty line. When you look at education, those that are higher, have a higher degree of education, this red line is a college grad, the purple line is some college, and then high school graduate, and I think that's a mistype. The other, I think the green was some high school. There's a definite and significant difference between the level of education and the prevalence of smoking. Why is that important? Well, it's the population we serve, right? I mean, CareOregon doesn't serve many people that are well above the poverty line. And our prevalence of smoking in our population is much higher. How many of you have seen this pyramid? Few, okay. So just to orient you a little bit, when you look at the health impact pyramid, as you go down the pyramid, the larger the impact on the population, okay? So at the top, it's sort of a one-on-one. I'm going to talk to you about your need to stop smoking, okay? You need to be healthy, you need to have more activity, etc. And then you look at the second level, clinical interventions. Those are sort of medications, okay? Long-lasting protective interventions are more on a population level. Immunizations, brief interventions, cessation treatment, which would be sort of behavioral therapy that's designed, okay? And then when you look at the last two levels, it's more of a policy or population decision, okay? Changing the context to make individuals' default decisions healthy. Those in this category would include fluoridation of the water, getting rid of trans fat, having iodine added, smoke-free laws, and tobacco tax. And that's primarily what I'm going to be talking about in the next couple of slides. How is it that we can bend the curve of the smoking prevalence, okay? And then, you know, we talk about the socioeconomic factors a lot. There's little that we can do in this room about this. It's poverty, education, housing, and inequality. We're here to focus more on what are the treatments and the prevention of the medical issues, i.e. COPD. But yeah, if we could get rid of poverty, many of the things above would inherently improve. So if you look at the last 20 years and compare the price of cigarettes to the prevalence of smoking, and this particular graph are those under the age of 18. There is an inverse correlation between price of cigarettes and smoking. I mean, it's really not a magic bullet, it's just a fact. So if you look at 1995, 1997 range, the price of cigarettes, and this is on 2017 adjusted dollars, so if in 2017 a pack of cigarettes on average costs $6.37 here in our country. In 1997 it was $2.98, those are 2017 dollars. The prevalence of smoking in youth at that time was 36%. Well, states have figured this out, and we figured it out at the federal level, but there's still many barriers. As the price goes up, the prevalence goes down. We've made a big impact on youth. I mean, it's still quite high at 8%. This is nationally. It's not. I mean, it's going to vary from state to state. But as we've increased cigarette tax, smoking prevalence has gone down. So New York State, they've really figured this out, and they're sort of leading all other states in this area. These are curves that are pretty much match what you just saw, except they apply to New York City. They have made headway on state policy and increasing taxes every year. And as they've done so, both the youth and the adult smoking prevalence has gone down. So here's kind of a summary of that. Cigarette use in New York in adults 14%, in the country 17%, among high school students 5%, and in the U.S. a little over 8%. Okay. Tobacco tax in New York State, their state tax is over $4 right now. This is 2016 numbers. And in the U.S. on average, it's about $1.70. Okay? So here in 2016 in Oregon, if you smoke a pack a day, it's a little over $2,000. In New York City, it's over $4,500 a year. What else do? They prohibit the sale of flavored tobacco products. They prohibit the sale of tobacco products to anyone under age 21. They don't allow tobacco products to be sold in pharmacies. They don't allow smoking in any public spaces, including stadiums like Yankee Stadium or Citi Field. And they require that cigarettes that are sold in packs of 20 cost $13 or more. Okay, so this is policy. These are things that at some point each state is going to have to face, and I'm kind of reviewing some of this with you is because some of this in this room are going to be involved in how we shape the future of our state. So we're going to sort of transition now into more of a COPD part of the presentation. I have a partner, his name is Bill Bauerfeind, and I was showing him the slide sets, and he said he has a script, and I'd like to share the script and maybe give you guys a pearl. He has a new patient that comes in. He will walk into the room, and they're an active smoker. He knows that based on the information that he's already gotten in the chart. He walks in and he says, "Yeah, one of your inhalers is killing you. I'm so glad you're here. It's amazing that you're here, and I'm happy because I think that we're going to be able to make a difference because we need to get rid of one of these inhalers." And the patient's like, "Wow, that's amazing. Are you what is it which one?" And, "Well, it's your cigarettes, and we need to get rid of that." And that's it. I don't think that patients they're either in denial, which often is the case, or they don't quite understand the correlation. It's really amazing to me when I'll see a COPD patient that's an active smoker that has every excuse in the book, but still wants the inhalers because they think it's going to, it's going to make them better. And there are some of the patients that I have, quite frankly, I will not give inhalers to because they're smoking. The amount that they smoke each day, it far outweighs anything that an inhaler is going to do, and their compliance is usually not that great. So when you combine therapies with behavioral counseling and medication, and my advice would be to address this each and every time the patient comes, if they're an active smoker, that if you combine behavioral therapy, the chances of smoking cessation are doubled. Okay. So this is, the formal name of this is the Fletcher-Peto Diagram. Some of you guys may have heard of a variation of this. It was published in the British Medical Journal in 1977. And the take-home here is that the rate of decline in lung function will stop, its slope will change when you stop smoking. So if you look at patients that never smoke or are not susceptible to smoke, there are such folks, their lung function at the age of about 35 will decline about, their forced vital capacity will decline about 20 milliliters a year, or 200 cc's, or a Coke can every decade, thereabouts. If you smoke, the rate of decline in lung function is much more rapid. Okay? However, at whatever age that you stop, your rate of decline in lung function then starts to match the slope of a non-smoker. So there's really no time that's too late to quit smoking. Okay? So COPD in the U.S., about 150,000 deaths each year, and there are approximately 16 million people with COPD in our country. If you take out unintentional injuries, it's the third leading cause of death in our country, at the rate of about 40,000 per 100,000 population. So as I mentioned before, most COPD, about 80 to 90%, is due to smoking. The other causes would be pollution, genetics, chronic infections, and low alpha-1 antitrypsin levels. Don't know that that matters so much in the populations that we serve. What are the costs of COPD in our country? In 2010, it's estimated that it cost about $32 billion. In 2020, $49 billion. And this cost is projected to continue to increase. $3.9 billion is due to the loss in productivity. Okay, how do we pay for this? Most of the dollars comes from the federal government. 50% Medicare, 25% Medicaid, and then much less from private insurers. So, the buckets of money, there aren't really, it doesn't matter that much. It's either you're going to pay in your taxes or we're going to pay in your premiums. It's going to be one or the other. So as far as states are concerned, in Alaska, it's about 42 million. In Florida, 2.5 billion. In Oregon, we're sort of right in the middle of that. So I'm going to spend a little bit of time on this slide. And we talk about COPD. How many of you have heard sort of like overlap, and how do you differentiate between COPD and asthma? What's burnt out asthma? What's the difference between emphysema and bronchitis? And I guess I'd welcome you to not try to parse it out that much. To think about, there's a patient that we call asthma. Yeah, there we go. And it would be in this area that we're numbering 9, and that's complete airflow reversal. Okay, that means that they have airflow obstruction on spirometry. We're going to talk a little bit more, maybe a lot more about spirometry. that completely reverses with a bronchodilator. Okay? That's not COPD. That's asthma. Let me also say that if you're outside of this box, in other words, if you don't have airflow obstruction as diagnosed on spirometry, then you don't have COPD. That's part of the diagnosis, okay? And then you have overlaps. You've got the emphysematous patient. Those are the pink puffers, right, that you've heard about. Those are the ones with holes in their lungs and bullous disease. Then you have the chronic bronchitic. That's the blue bloater, right? Those are the patients that produce a lot of mucus. And the overlap is, you know, a patient that we often see that you have some degree of emphysema, some degree of bronchitis, chronic mucus production, and then sometimes this will overlap with some bronchoreactivity that doesn't normalize, okay? Then you have an area that's designated 10. Those are patients that normally we wouldn't categorize as COPD, like a cystic fibrosis patient, etc. But the key here, the key take home here is if you have persistent airflow obstruction that's not completely reversible on spirometry, that is COPD. Okay? It doesn't matter if you also have asthma, it doesn't matter if you call it bronchitis or emphysema, that's the definition. Okay? So, how do we diagnose? How much time? Okay. You diagnose based on symptoms, you diagnose based on risk factors, you diagnose based on spirometry. It's those three things. That's all you need, okay? So I'm going to make a lot of plugs here for spirometry because frequently we're seeing patients in our clinic that have never had that, and they have a diagnosis of COPD. You can't have a diagnosis of COPD without spirometry, and it's my opinion that even though some of the studies have shown that primary care clinics don't do a great job of spirometry, I think that that's sort of in a way, a falsehood. It's a matter of training. All of our MAs know how to do spirometry. All of the MAs and all of the primary care doctors' offices, it should be able to at least have some of them trained to be able to do it. That will eliminate under and over diagnosis. So the symptoms, what are the symptoms? Dyspnea, cough, sputum production, what's the risk factor? Smoking. And spirometry, as I mentioned, is the presence and severity of persistent airflow obstruction. I don't need to go into the details. We used to say that does everyone know what an FEV1 is? Okay, you've heard of it. It's how much air you blow out in the first second of the spirogram. And the forced vital capacity, or FVC, is the volume that you've blown out at 6 seconds or more, okay? So if that ratio is less than 70%, we used to say COPD. Now we have a little bit fancier algorithms that the spirometer machine will output the lower limit of normal, which would be the 5th percentile. And, there's a little bit of wiggle room there. Sometimes we will say if it's 70% and they have symptoms, but they don't hit the lower limit of normal. But if you look at European Respiratory Society and ATS, they'll say lower limit of normal or in the 5th percentile. So if that obstruction is there, then it's COPD. Oh, let me go back. There's one thing I wanted to mention here. So, excuse me, other parts of the assessment, and we'll kind of get into this in the last part of my talk in the second half. It's important to know the comorbidities, meaning do they have ischemic heart disease, do they have obesity, do they have sleep apnea, do they have a metabolic syndrome, what are the comorbidities, what is their access to health care, what is their living situation, what's going on in their family, that all the other external social stressors that many of our patients have difficulty with. We also want to know what is their rate of exacerbation. Do they have 0 exacerbations over the last year, 1, 2? Did they go to the hospital? Did they go to ER? Those are all important factors to tell us whether or not we've got some control of their COPD. I won't spend a whole lot of time on this. It's just that without spirometry, we're not good. We're not good at estimating the severity of a patient's disease. And this was a kind of a cool study, about 900 patients. 83 clinics, and so if you look at the physician estimation without spirometry, they underestimated the severity of disease in 40% and overestimated in 29%. Patients did about the same, but they did better than the docs in estimating what their spirometry numbers were going to be. So this is this number. Physicians underestimated relative to what the patient felt like. So there's a disconnect there between what the physician understood what the patient was feeling. Okay, patient felt worse more often than what the physician recognized. Okay, so a couple take-homes. Physician underestimates the severity in about half of the diseases, about half of the patients without spirometry. Okay, they were less severe than their patient's self-assessment. And after reviewing spirometry, the results changed the physician's opinion about the disease severity in only about half, and it changed treatment about a third. Okay, so even with spirometry, many physicians didn't know what to do with the number. Okay, the final take-home is that it's essential to get spirometry in all patients that you think might have COPD. Okay, we're going to talk a little bit about GOLD. Is everyone here familiar with the GOLD criteria or heard about GOLD, the COPD? What GOLD has been around for a couple of decades. It's a policy-driven group of what would be recognized as national experts in pulmonary care who come together every 10 years or so and revisit all of the data and all the literature relative to COPD and then make some fine-tune adjustments of what diagnosis and treatment recommendations they feel are most appropriate on a population basis. Okay? So I think the last variation was in 2006 with some big changes. So when assessing a COPD patient and assessing their symptoms, it's really, really helpful to kind of categorize them based on their symptoms and exacerbations. And so there's this COPD assessment test, which is, if you're in primary care clinic and you have to go through this with your patient, it's going to take up a significant portion of your time. So I would say if you have time to do this with the patient, then great, do it. But there's another that's a lot quicker and a lot easier that I would almost rather you do, because I don't think it's going to matter that much. Most of the patients are going to be more symptomatic than not. The cutoff here is a total score of greater than 10. So it includes cough, phlegm production, chest tightness, dyspnea and dyspnea on exertion, limited in activities at home, and then it gets into even more severe symptoms. I'm unable to leave my home, I don't sleep well, and I have no energy. So if you have about 3 of these that are 2 and the rest that are 1, you're already there. You're already in a category that we would consider more severe from a symptomatic standpoint. So what I usually do, because I don't have all the time in the world, is just use the MMRC grade. And it's really just based on dyspnea. It's not as if I don't ask what symptoms they have. Do you have cough? Do you have sputum production? What's your sputum production per day? And what does it look like? And I'll add that in sort of as a, yes, that's another major symptom complex. But the dyspnea score is pretty easy to ask. And really the cutoff is, do you get shorter breath more so than people of your same age when you're just walking on a level surface, or do you have to stop for breath when walking on at your own pace on a level surface? And most of the time, by the time the patients see me, they're going to be in grade 2 or higher. So it's a pretty easy way to screen for shortness of breath and symptom complex. So here we go. This is the all-encompassing slide of. Did you have a question?
I don't want to interrupt.
That's fine. Go ahead.
Quick question. So the CAT scores seem more specific for COPD, but the other myospec scores seem like you wouldn't be able to tell if that was heart failure or COPD or other reasons for dyspnea.
You would not. And you know, I don't want to minimize the symptoms that COPD patients have, like cough, sputum production, mucus production. However, if you're thinking that the patient has COPD, if they have risk factors for COPD, and they have dyspnea, you don't know if they have heart failure or not. What's the next thing you're going to do? You want to get a spirogram to see, right? So, I mean, it's going to guide what your next test is going to be. I mean, and then you do a physical exam, and you know, do you have signs of heart failure, you have edema, you know, and coronary disease, other risk factors. But yes, it's not specific. Nor, I mean, if you were to take this from a pulmonary standpoint, the COPD assessment test is not specific for COPD. It could be pretty much any mucus-producing lung disease, right? So we'll revisit this slide a couple of times. So how do you diagnose? You need assessment of risk and symptoms and assessment of airflow limitation. So when you look at the degree of airflow limitation, I know GOLD still says we use FEV1 to FVC ratio of less than 70%, and that's fine. If you want to do that, that's totally fine. We're not going to miss that many people, and we're not going to overdiagnose that many people. So the severity of the degree of obstruction: mild, moderate, severe, very severe. And the cutoffs are 80%, 50 to 80%, 30 to 50%, and less than 30%. So we have a cutoff between mild and moderate, and then severe and very severe. Your exacerbation history is something that needs to be taken as well, or the patient's exacerbation history. So if you have any hospitalization due to COPD or 2 or more ER visits, that's a severe category, okay? If you don't have any exacerbations or you have 1 ED visit, that is in the more mild category. Okay, so Gold Class A, Gold Class B, those are our mild patients. Gold Class C, Gold Class D, those are our severe patients, okay? So if you have let's say you have grade 3 obstruction, and you have no exacerbation, and you have, or you have no ER visits, it still puts you in a severe category, okay? If you have only mild obstruction, but you go to the ER twice, you're in a severe category, okay? Then you can categorize between, you know, C and D or A and B based on your MMRC score, okay? Does that make sense to everybody? Okay, so it's symptoms, exacerbations, spirometry. Those are the 3 things. And then all you have to do is just kind of put it in. Any question about that? Okay. So I know Mariah's going to go over this in much more detail. And hopefully everyone here knows what a SABA, LABA, LAMA, ICS is. Do we know? Don't be afraid. Short-acting, long-acting, and then a beta agonist and muscarinic antagonist. Okay, so really it's the albuterol groups and the tiotropium groups or the ipratropium groups. Okay, so one of the bigger take-homes here is that we don't prolong life with inhalers. The things that prolong life are smoking, oxygen, and lung volume reduction surgery, which we're not going to talk about at all. But those are the only 3 things that we know over multiple trials will prolong survival in a COPD patient. The rest will decrease exacerbations, improve symptoms, shorten exacerbations like prednisone. Okay? Even palliative care will improve symptoms and decrease hospitalizations. We could probably give a whole talk just on the palliative care approach. Okay? So other things that Mariah will probably talk about: chronic macrolide therapy, roflumilast, if I'm saying that right. Pulmonary rehab. I know Heather's going to talk about this. It's probably about as good as inhalers when we're looking at patients with severe COPD and improvement in symptoms. Don't use theophylline at all. There's no clear benefit, okay? And then the rest you can read. How am I here on time? Okay. Am I close?
We have like about 10 minutes.
Okay, I'll try to get through this. So I'll spend a little bit of time here, but most importantly, I want you to start to look at your handout here with respect to the CareOregon COPD treatment pathway, which I think makes better sense than GOLD. The reason, Group A, short acting. That's all you need to know. If you're in Group A, you have mild disease, no exacerbations, few symptoms, it's a short-acting inhaler. What GOLD says between Groups B and C is use a long-acting inhaler. And they don't really differentiate, they don't say which one, and they don't say if you should really add another in Group C. It gets a little bit vague, okay? And then by the time you have even more severe disease, GOLD says, well, think about adding a bunch, you know, and then considering other oral therapies like chronic macrolide therapy. So to me, this pathway seems to make much more sense. So we'll go through, and this is a CareOregon formulary as well, but we'll talk a bit more about just the generic. So for short-acting beta agonist, Ventolin, ProAir, whatever your choice is, patients in Group A, they're low risk with only occasional dyspnea, they get a short-acting inhaler. They don't need anything long-acting. When you're Group B, that's when you add a long-acting inhaler. And usually, I think we err on the side of a muscarinic antagonist, like a Spiriva, okay? Or like Incruzalipta. And I think that that's probably favored without data necessarily by most of my partners. When you get to Group C, you need two long-acting inhalers. You need a LABA and a LAMA. You need Ceravent and you need Spiriva, basically, or the combination that you see up here. By Group D, you're just adding one more therapy, and usually that's an inhaled corticosteroid. There's some caveats here. If you look at Groups B and C, especially if you have a lot of bronchoreactivity in a patient, and they have a smoking history, and some of the bronchoreactivity is not completely reversible, there is a role for looking at an ICS LABA combination in that population, but I think by and large, if you follow this pathway, you're going to be fine, okay? If there's ambiguity and they're in the severe category, many times those are the patients you're going to be referring to the specialists, okay? And we'll talk about some of those criteria and relationships between primary care and the specialist in pulmonary later in the day. All right, that's the first part.
We have a couple of minutes for questions, folks, before we move to the next segment. I do ask, please, if you do have a question, raise your hand so I have a minute to come over and get the mic to you so that we can make sure you're heard.
And I'll repeat it, too. Sir.
For the group with the asthma component, you briefly touched on it at the end. You would potentially be okay adding an ICS or including an ICS earlier. Is there any harm that you could do with that, or is that only with asthma patient? There's a group of patients.
So there are some data that show that ICS exposure leads to a higher risk of developing pneumonia. So I think that if there is not significant bronchoreactivity, that's something I would totally shy away from, okay? And it's not super strong data, and some of it's just correlation, but it looks like, and it feels like, it looks like to most of us that there is an association there. However, the benefits in a patient with a significant reactive airways component far outweigh the risk of the potential of developing a pneumonia as related to the exposure to an chronic ICS.
Any other questions at this point in the proceedings here, folks? All right, well, Dr. Cummings will be back towards the end of our session here today to do a secondary presentation. Let's give him a warm round of applause, please. Thank you.